a todos, buen día. El día de hoy tengo el honor de presentar a grandes ponentes que van a estar aquí con nosotros. Van a estar desde Tailandia, Colombia, Ecuador, México. Mi nombre es Manuel Martínez y primero que nada quiero dar gracias a la Universidad Biosman por hacer esto posible. Vamos a ver hoy los temas en vanguardia e innovación en la reparación del manguito rotador y vamos a dar inicio con nuestro ponente estrella desde Tailandia, el doctor Bancha Chernchujit, quien está en la Universidad y Departamento de Ortopedia en la Universidad de Bangkok, Tailandia. Él nos va a hablar del híbrido en reparación del manguito rotador, la reparación con y sin nudos, la nueva técnica rápida y menos invasiva. Dr. Bancha, if you would like to start your presentation.
Okay, thank you. Good afternoon. Thank you for the invitations. I'm Dr. Bancha Chernchujit from Thammasat University, Thailand. So today I'm talking about the hybrid knot tying and knotless rotator cuff repair, the new speedy, less invasive techniques. So this article changed my techniques of the rotator cuff repair. So we found that many of the patients have come back with the torn rotator cuff after the knot tying. So you can see that from this video, the vascular obstruct by the knot tying. You see that? So that's why there is the report mentioned about the type 2 tear or musculotendinous tear after the knot tying, conventional suture bridge technique, right? Because of the vascular strangulation and the torn is always at the knot tying level. So this problem is less common in single row and knotless suture bridge technique, right? So I read the article from Dr. Yongger Lee. He mentioned about his arthroscopic modified Mason and lens comparing knotless and knot tying. He found that the knotless suture bridge significant lower lethality comparing with the knot tying group, 5.9% comparing to 72%, right? So I did the study comparing the conventional knot tying and the knotless suture bridge and evaluate the average pressure and contact area, also the pressure distribution, comparing this conventional knot tying and the knotless knot tying. I used the 2 triple loads, so that's totally 12 sutures. We call a dozen knotless suture bridge technique. So we found that at the medial footprint, there's very high pressure, 51% comparing to 43%, right? That's why the medial footprint at the medial side of the knot tying have torn because of the high pressure at the knot tying level. And this is about the contact area. We found that a dozen knotless suture bridge technique have better pressure distribution, I mean the better contact area comparing to the knot tying, 76% comparing to 65%. And we did the clinical studies comparing the conventional suture bridge and the knotless suture bridge. The result, we have better result in the knotless group. The patient have less lethality, okay, 0% in pattern 2 and 30% in pattern 3 comparing to the knot tying. So this is the patient that referred to me because he has a type 2 tear after the rotator cuff repair, okay? So the patient had pain and weakness after the repair. You can see that the patient had the torn proximal to the knot tying. So the cup healed nicely, but the problem is that the patient have torn proximal. It's a type 2 tear. So we get in and we did a revision. You see that at the level of the knot tying, that is a tear. So we need to revise and repair the back again, right? So this is the way we do. We call the musculotendinous tear, like the tension band techniques. So we didn't tie the knot, okay? And we pass the suture from the proximal to the footprint, right? So this is our technique, the musculotendinous repair. And we found that the patient have good result and the cuff healed nicely after the revision. Okay. So we report the technique of the musculotendinous tear, okay, using the lateral row anchor to avoid the cut through. Okay, you can read my article in arthroscopy techniques. So after that, I changed my concept. I changed my techniques of the cuff repair to be tension-free repair. Dosen, knotless suture bridge technique is more anatomic reduction, less dog ear formation, better pressure distribution, and decrease the tension at the musculotendinous junction, result in type 2 tear, right? So my friend Dr. Juan O from Korea, he discussed with me. He told me that, oh, your technique look really nice, Bancha. Why don't you put the camera into the joint after the cuff repair? Okay, you want to see what happened inside. So I follow. I believe him, and then this patient, I put the camera. You see that after the knotless suture bridge technique, it look nice, right? But when I put the camera into the joint, I'm surprised. Oh my God. Okay, you see that? There's a gap underneath. Okay, the rotator cuff, I didn't tie the knot at this level, but in the back, okay, I tied the knot, right? We found that in the back, the cuff looked nice contact, but I didn't tie the knot at this area. That's a gap underneath, right? So after that, I think over again, what should I do? Okay, outside look nice, but inside they still have gap when you didn't tie the knot. But anyway, when I do the MI study, we found that this patient healed nicely, but I'm not sure that the healing inside has good enough. Is like scar healing or not, right? Because there's a gap underneath the rotator cuff. So that's why I have a new idea about the hybrid knot tying and knotless. Okay, we call this the 3-in-1 hole, right? We have the only 4 holes in the rotator cuff. We have 2 anchors. This is the triple load anchor. So 1 anchor, we have 6 limbs, right? So 2 anchor, we have 12 limbs. So we pass this suture into 4 holes. Okay, that's why we call 3-in-1 hole. So this technique have less trauma to the cuff because you pass to the cuff only 4 times, right? So, and then we do the limited knot tying. We do 1 in the front, 1 in the back, 1 in the middle, only 3 knots. And then we do the suture bridge like this way, okay? So this is my idea. We call the 3-in-1 hole, okay? Hybrid technique. So this is after the repair, okay? So I show you one example. This patient has 67 years old, he have impingement and also the rotator cuff tear, okay? She also have an AC joint and bicep problem, right? So when I get in, I cut the biceps, okay? And after that, we do the decompressions, okay? This is a spur. We do the subcommion decompressions. And also we do the AC joint resections. This is AC joint, right? This is after the AC joint resection. And then we do the cuff repair. So this patient have the small size tear. So we make a microfracture at the footprint to promote the healing. Then we put 2 anchors at the medial row, okay? I prefer the triple loads, okay? And then we pass the suture into 1 hole, 3 sutures into 1 hole, right? 1, and then the second one. So the distance between each hole is about 8 millimeters. I will not put it too close because from the article we found that if you put it too close, like 5 millimeters, you can cut through the tissues, right? And after that, I just tie limited knot tying, okay? For this patient, 1 in the front, okay? And 1 in the back, okay? I prefer to tie the black tiger, okay? And then we do the suture bridge. So this surgery takes only 40 minutes, okay? It's very fast because you just make 4 holes and then you just tie 2 knots and make a suture bridge, okay? So for the lateral row, 1 hole, I will put 6 suture in one hole. Okay, like that way. Okay, and then we try to spread the cuff as wide as possible. Okay, so this is the 3-in-1 hole. You see that is nicely reduced, and also there's a good pressure distribution. So in some patients, this is an L-shaped tear, right? We need to design. So I plan to put 1, 2, 3, and 4 holes. Okay, like these patients. Okay, so I pass one in the front. This is a anterior comma tissues. Okay, always to anchor, and then I reduce the apex first. Okay, using the suture hook, and then pass the suture into the rotator cuff. So I think the distance between each hole is quite important. You should not put it too close. Okay, and then reduce the apex. Okay, and then I try to put my lateral row as wide as possible. One in the bicipital groove, another one close to the infraspinatus insertion. Okay, in this area the bone quality is quite good. Okay, from the study. Okay, so this is the L-shaped tear, right? From this study, we found that if you put the suture too close to the rim, it's not good. You should put it close to more proximal to the rotator cable. And the distance between each hole is also important, right? 5 millimeters is too close. If you tie the knot, you can cut through the tissue. So my distance is about 7 to 8 millimeters, right? So like sometimes we can do the knotless suture bridge technique, like the bursal side tear. I try to preserve my articular side, okay, by making just the bursal side and then doing the knotless, right? We do it like parachute, right? This is using only one lateral row. You can reduce the bursal side tear, right? So this is quite simple, and also have a good results using this knotless suture bridge for the bursal side tear. Okay, I try to preserve the articular side. This is cost effective. It's safe. You can save money because you don't need to put the medial anchor because the articular side is still intact, and decrease the retaliate. Okay, using this technique. And we published this article, the knotless suture bridge technique in high-grade bursal side tear. Okay, using the only lateral row, no medial row, preserving the articular surface, right? And we report the result is pretty good. I prefer the B-chair position, and this is my portal. Okay, I always use about 5 portals like this. Okay, 1 in the back, 2 at the side, and 2 in the front, right? So I will use only 5 portals. In the patient have massive tear, I try not to. I will go directly into the subcommon space. Okay, I will not penetrate to the posterior cuff. Okay, and this is another patient. She has a very massive tear, external rotation left side positive, good subscapularis, and weakness of the supraspinatus. She has a very big size tear, right? So very important, you need to make it tension free like that. Okay, release the rotator cuff from the coracoid process, right? Coracohumeral release. Okay, release the cuff from the roof, and then reduce the apex, right? And release the cuff from the glenoid also. I put triple load for the medial row, and then we do make the apex reductions. Okay, and this is a suture bridge, my high bridge suture bridge technique, right? And this is the result. She has the very massive tear, but anyway, we can release and make a good result, good healing after the surgery. So this is about 2 years after the surgery. The patient have better result and also the good functional outcome, right? So another example, this is 47 years old. She have the medium-sized cuff tear. So this is another 3-in-1. Okay. So the trick is when you do 3-in-1, you cannot pass 3 suture in one shuttle because 3 is too big. So the trick is you put 2, right? You put 2 in 1, in one knot, another one, okay, in another knot. So you can make it pass 2 times, right? So like this, okay. So this is the way we do. I prefer to use the spectrum, okay. So that way. So this is the 3-in-1. Okay, make a knot tying, limited knot tying. Okay, and then make a suture bridge. Okay, like that way. So in the middle, I tie the knot, one in the front, one in the back, one in the middle. Okay, like that. Okay, and then we make a knot tying. Same. I prefer to put the anchors very close to the bicipital groove because of the good bone quality. Another one close to the infraspinatus. Okay. Like that. So this is final repair. And then we check again. We put in the joint. You see that using this technique, there will be no gap. You see, there will be no gap underneath the rotator cuff comparing to this knotless. Okay. So now I change from my knotless to be high bridge. Okay. Combining the knot tying and the knotless. So this is a very massive cuff tear, has traumatic cuff tear for 6 months, external rotation, leg side positive, pseudoparalysis, okay, and also bicipital pain. So you see that the patient have proximal migrations. I discussed with him about the reverse or try to repair the cuff, okay, because this is 6 months and the patient have pseudoparalysis, and also they have supraspinatus and infraspinatus torn. So when we get in, we found that the patient have a very big size tear, suprainfraspinatus, and retraction is so far. We do the bicep genotomy first, decompressions, and then we do the cuff mobilization. This patient, the cuff is quite retracted so far. It's like a pate 3, okay, and a lot of scar tissue. So this patient, we do the cuff release from the coracoid process. Okay, release the cuff from the loop and also the coracoid process. Okay, after that, okay, we put the anchors. We put 3 anchors on the medial footprint. Okay, so after the release, the cuff mobility is getting better. So I think this is the key. You need to release the cuff from the coracoid process like that. Okay, release the coracohumeral ligament. Okay, and then test the cuff mobility again, right? And then also release the capsule. Then this patient also have stiffness. I release the anterior capsule and IGHL anterior capsule. Okay, and then we put the footprint, 2 anchors on the medial side, triple. So this patient, I put 3 anchors on the medial side. Then we make a 3-in-1 holes. Okay, like that. Okay, and this is the final repair. Okay. So this is the high bridge, knot tying and the knotless. Okay. So the key is a tension-free repair. So this is 1 day after surgery. We do the very slow rehabilitation, 6 weeks. Okay, I put the patient in breast for 8 weeks. Okay, and this is 3 months. The patient getting stronger and better range of motion. This is 3 months. Okay, and his cuff strength is getting much better. Okay, infraspinatus and supraspinatus. Okay, and this is MRI after surgery. Have good healing of the infraspinatus and the supraspinatus. So we collect the patients, have a very good results. Okay, comparing to our knotless and knot tying techniques, we found that the patient have better quality of the rotator cuff using the Sukaya classification. So for the knot tying, we still use the SCR we still use knot tying for the superior capsular reconstruction because the tissue is quite thick. So if you do the knotless, I think it's not good. The patient may have re-tear. So we try this knotless for the SCR. It's failed because the cup is very thick. Like this patient, I prefer to use the big chair position. This is my position. I put the patient in adduction, internal rotation, and also I have two teams. One team harvesting the graft, one team doing the arthroscopic preparation, right? We have the 5 portals, okay, like this. Yeah, this is the SCR. So the SCR, the cup is quite thick. The tissue graft is quite thick. It's about 1 centimeter. So if you use a knotless, I think it's not good, right? So I still use the knot tying for the SCR, superior capsular reconstruction, okay? So this is harvesting the fascia lata and preparing the bed, like that, okay? Okay, put 2 anchors on the medial side. Okay, I prefer using the triple load, right, on the medial side. So after preparing the bed, we are measuring the size of the tear. Most of the time it's about 4 centimeters by 5 centimeters, right? And put the medial anchors at the glenoid. Okay, I always use the 2 anchors at the glenoid side, using the triple load anchors. Okay, like that. So 1 in the front, 1 in the back, triple load. Okay, and after that I use the side to side repair. Okay, 1 in the front, 1 in the back. Okay. Okay, and after I repair, I always use I put my rotator cuff over my graft like that also, right? So we do the bed preparations. Okay, so after we're ready, now we put the anchors at the footprint, 2 anchors at the footprint, triple load also. So that will be totally 12 plus 12 is the 24 sutures. Okay, and make a side to side also. Then we pass the graft. I use my finger to dilate first. Okay, and then we pass the graft into the joint like that. In big chair position is quite comfortable. I think it's easier than the decubitus position, right? Then pass the graft in. Okay, like that. Okay, and then we make a knot tying. Okay, so we pass this graft in. So the size of the graft, the thickness is very important. It should be at least 8 millimeters. Okay, and for Thai people, the width is around 4. Okay, and then we make a side to side. Okay, we repair the cuff to the left. We repair the graft to the left of the cuff, and also we repair to the glenoid side. Okay, so that is a knot tying, and then we pass the we put the graft, put the rotator cuff over the graft again. Okay, like that. Okay, like that, like that. This is a rotator cuff covering the graft. And then finally we make lateral fixations, like we do the rotator cuff, double row cuff repair. Okay, but I prefer 12 because using 12 you have better pressure distribution, right? Because the cup healing need pressure, good pressure compression. So that's why I put 12. Okay, and we have pretty good result with the superior capsular reconstruction. Okay, so this is the final repair. Okay, so this is pre-op, post-op. You see that the HI is getting much better after the surgery, and there's a good healing of the superior capsular reconstruction graft. So this is a clinical outcome. The patient have good function and also has good strength of the rotator cuff. Okay. Okay. So in conclusion, this hybrid knotless and knot tying technique, the 3-in-1 hole technique, we have 3 pairs of knotless, 3 pairs of knotted. It's less trauma to the rotator cuff because you only 4 holes, less blood supply disturbance, and less strangulation, less operation time. Okay. So this is the new technique that I want to share with you. Okay. Thank you.
Well, thank you so much for your presentation, Dr. Bancha. Thank you for sharing those cases with us and for those amazing videos. I think it's really clear that you're an amazing surgeon. Thank you.
Thank you.
Ahora vamos a estar